So in this video, I will show the most important things to remember about crescentic GNs. First, to show how they form, um, I will use an example of anti-GBM disease, where one forms antibodies against the glomerular basal membrane. So this will result in uh, basically focal inflammation and complement activation and breakage of the basal membrane with resultant basically bleed into the urinary space. And then the proliferation of epithelial cells will occur, and we call that crescent formation. And that's basically um, how it would look like. So here you have a silver stain showing glomerular tuft. In the middle you have fibrinoid necrosis, and then you have also these epithelial cells with several also inflammatory cells in between. And this is basically how crescent would look like in its very kind of like early cellular form. If you were to stain this with immunofluorescence fibrin stain, this is what you would see. So this is a tuft here that is basically negative, and then you have this basically reactivity in between the cells that are accumulated in the urinary space. This is how we differentiate real crescents from pseudocrescents. Pseudocrescents really don't contain fibrin. They're not associated with inflammatory lesions or extravasation from the capillaries, but it's associated really with proliferative changes of epithelial cells in reaction to podocyte injury. So that's different, but this is a crescent. And I showed you a cellular crescent, like here you have another one with epithelial cells, also inflammatory cells, and then fibrin in between them. And eventually, as the time goes on and collagen deposits in those areas, you will see something that looks more like this, like a fibrous crescent. So we have progression from cellular to fibrous crescents. And this is basically what is left of the tuft here to the left, and then you have this small portion also kind of like split off the main tuft over here. So that is how old crescent would look like. Crescentic GN is not a single disease. It's a pattern of injury that you may see with anti-GBM disease, as I just mentioned in a previous example, but also ANCA disease or post-immune crescentic GN. Immune complex-mediated diseases can be also they may present with very aggressive form and crescents, lupus nephritis, for example, post-infectious GN, MPGN. IgA nephropathy can also have crescents in its proliferative forms, but also a number of other diseases that are all listed here. Therefore, you really need actually immunofluorescence studies to tell you what is really depositing. So if you have linear staining for IgG, you think of anti-GBM disease. If you have granular staining with different things, for example, in lupus nephritis, you will have full house immunofluorescence with granular staining for all sorts of things. In IgA, you may have only IgA and C3 and kappa lambda. And so on. So you will see by immunofluorescence, you will see granular staining. And then in post-immune disease, which is most commonly ANCA-related, you will see no deposition by immunofluorescence. This is just to show you how crescentic GN really distributes over different age groups. Anti-GBM has this kind of like bimodal distribution. Immune complex GN is more common in younger, and that then it kind of fades out with age. And then post-immune kind of like does the opposite thing. It's more common in older people and over 65. It's actually really the most common form of crescentic GN. But in younger people, it's not really that uncommon either when you think about it. 35% in people that are younger than 20 years of age. Anti-GBM disease really occurs when you have injury to the collagen 4 hexamers, or these trimers basically, which under some oxidative stress may dissociate. And you see that, for example, in smoking, but also in other toxic exposures. So you will have basically dissociation of these triplets, and then different epitopes may actually get unveiled by that dissociation, and then immune system recognizes them as foreign, and you may build antibodies against that. Similarly, we may see antibodies against GBM in patients with Alport syndrome that are transplanted, and their immune system doesn't recognize the normal GBM as normal, but rather as foreign, and then they can build different antibodies against GBM in that situation. You will basically see this linear distribution, because antibodies from the circulation will bind to antigens diffusely along the glomerular basal membrane. And it will, because of the distribution of these antigens, and antibodies bind to them basically in situ, because of that, you will see this kind of like linear distribution. And for the same reason of that distribution, you will really see no deposits by electron microscopy when you look at the glomerular basal membrane. So those deposits will not be easily visible. In ANCA disease, the mechanism is still somewhat murky, but seems that some people produce antibodies against different neutrophil cytoplasmic proteins. So basically, when neutrophil gets activated, it degranulates these proteins like proteinase 3 or myeloperoxidase, and then those proteins get to the surface. And if you do have these antibodies in circulation, they will bind to the neutrophil surface, and that will actually initiate the injury that will result in release of these proteinases and enzymes from the neutrophil, and that will cause basically injury to the small vessels, and you will end up with small vessel vasculitis. And similarly, in the glomeruli, you will have focal necrosis that will initiate crescent formation. So these proteins within the cytoplasm of neutrophils most commonly are proteinase 3 and myeloperoxidase, and a pattern of staining that is associated with it is called C-ANCA or P-ANCA. And before I get into P-ANCA and C-ANCA, let me remind you that when you look at the immunofluorescence microscopy of the kidney tissue of people that have ANCA-related Crescentic GN, you will see pauci-immune glomerulonephritis. So there will be no staining there. That is direct immunofluorescence. But when you test those patients' sera, so you will basically use a glass slide with test cells from somebody's neutrophils, and those are bound to the glass slide and fixed with alcohol, and then you put patient's serum and a secondary antibody, and if there is actually a proteinase 3 antibody or anti-MPO, you will actually see that binding, and the secondary antibody will recognize those antibodies. So if the distribution is cytoplasmic, you will call that C-ANCA, and if the distribution is perinuclear, you will call that perinuclear or P-ANCA. And here is also an example of how ANA looks like on immunofluorescence. So as you can imagine, this is not read by a machine, but read by technicians, and sometimes you can have some subjectivity actually involved with the reading. ELISA is a little bit more specific, I would say, and more automated. So the way that works is, for example, if you have a test plate that has antibody with known antigen, for example, myeloperoxidase or proteinase 3, and then you apply patient's serum that has antibodies. Once you add secondary antibody, you can actually then detect that antibody if it has, detection device attached to it, and basically then you can read that out as positive or negative, and you can even give it a number as a titer. That is how ELISA works. So once you actually have positive p-ANCA or c-ANCA by immunofluorescence, then you will confirm the test with ELISA. ANCA-related kidney disease is basically most of the time of unknown etiology, like many other kidney diseases, but we know that some forms of ANCA can be drug-induced, and here you have several drugs that can do that. So just remember, Crescentic GN is not a single disease. Anti-GBM is probably the most severe form of glomerulonephritis in general. Unfortunately, it's not very common. But post-immune or ANCA-related Crescentic GN is very common. Don't forget that there are all sorts of other kidney diseases, mostly immune complex mediated, but also others that can present with Crescentic GN. Thank you very much for watching.